All right, welcome. I'm Danish Pari, and I'll be reviewing this topic, botulinum toxin, an overview. This should form a foundation for your understanding of the Botox lectures or botulinum toxin injection lectures for later indications such as blepharospasm, migraine, and so on. So, I would like to dedicate the talk and the series of talks on Botox to the memory of my father, who passed away in 2016 and really encouraged me to do more and more education and teaching. And so, all I do is mostly from his encouragement. So, in this particular topic, what I would like to achieve by the end of this talk would be for you to be able to describe the essential features of botulinum toxin, such as its mechanism of action, subtypes, common uses, storage, and for safety. And I want you to be able to explain the recommended process of reconstituting botulinum toxin for injections. And we will briefly discuss the immune resistance and associated factors along with tips and tricks. So let's start with a clinical context. Let's think about one of our patient, let's say presenting to our case, named Raza, and he is presenting with a concern for blepharospasm. So he's a 43-year-old male. He presents with history of difficulty keeping his eyes open, especially when driving in bright light. You diagnose him with blepharospasm, and he has tried and failed levodopa, baclofen, and clonazepam, multiple oral medication. You explain to him that the botulinum toxin injection would be the most appropriate and effective therapy. Actually, should have been the first line even before trying other medication, but affordability sometime or reliability can be an issue. And now he agrees and he asks you, when can I go back to the driving? Meaning, how soon will it be effective and how quickly would I know that it's working? He requests if the shots can be done today. So, he may have a trip coming up and he's worried about the cost and does not have a lot of money on him. So he's asking you, okay, what options you have that may be cheaper than the others. You remembered that you did the shots on another patient 2 days ago and have some leftover solution from that patient that you just never threw away. You check into the fridge and get the vial. You notice that the fridge was turned off at some point and did not get turned back on through, though the room feels chilly, it's not very hot, the sandwiches in the fridge are still fresh, so you think that, drug is probably still, the vial feels cold, the glass vial. So, a lot of red flags, right? But the question is that would you do injections on Raza and would you do them today? Would you use this vial that you're going to do? What would you tell them about the benefit of shots and what would you explain if the shots don't work? What's the next step? What would you do next? So we will be addressing these kind of questions as we understand and learn about botulinum toxin. But let me start with the basics or first discovery of botulinum toxin. Botulinum comes from food poisoning. The word botulus comes from the undercooked blood sausages or blood sausage, botulus. And from there, the word botulus poisoning or botulinum food poisoning comes in. This mainly became very notorious or notable during Napoleonic Wars, where there was a lot of scarcity of food and there were big spikes in food poisoning in various parts of Germany and France and Austria. So Johann Ortenreith from University of Tübingen, he was the first one to propose that the botulism that we're seeing or this presentation of a paralysis of a patient is likely related to undercooked blood sausages. So we're talking about 1810 or 1800 to 1817. Now, the first detailed description of what exactly this disease is comes from the remarkable work from Justinus Kerner. He wrote a report on outbreak of the botulinum food poisoning in Wildbad, Germany in 1793. In 1817, he published his report. In 1820, he wrote a definitive monograph on botulism. In 1822, he expanded it to a detailed monograph on botulism that provided us most of the insights about botulism that we had since then. So he described that you can actually reproduce the abnormality or problem from an animal model. So, for example, you can take a mouse or someone or hamster and you can take some of the leftover food that may have caused the problem and you can inject into the mouse or hamster and cause the same weakness or paralysis or even death. He even did some self-experimentation in a controlled fashion, did not lead to any of his own mortality. He basically was putting drops of the extract from the poisoned food on the tip of his tongue and was experiencing some of the dry mouth that we now use it for. He proposed that it's a zoonotic poison, meaning that animal related. Back then in 1822, the concept of bacteria was still not described, but he proposed that it's some kind of a microscopic animal which is now bacteria, we know it, that is probably producing this poison. And he proposed that this poison probably blocks the transmission of the nerve to different areas, not only muscle but also gland, because he was describing dry mouth and loss of sweating, which is also a non-muscular benefit of botulism. And he proposed that if you can extract it and purify it and quantify it, you can probably use it for therapeutic reason, for tightness muscles and for excessive drooling and so on and so forth. So he was also on the money for that. So, what is botulism that was being described in these monographs? It's an acute, generalized, descending, flaccid paralysis. So, it's a flaccid paralysis, meaning that there is decreased tone. So, it's a lower motor kind of a paralysis. It's descending, so it starts from the top, from the cranial nerve and face and bulbar area, and then goes down the upper limb and then down the lower limb, involving the respiration. It sets in 8 to 36 hours, so it can be as quick as 8 hours after exposure, but as late as 36 hours after exposure. That probably is dose dependent. Also causes, besides the paralysis, dry mouth and trouble swallowing, abdominal pain and constipation, retention of the urine, descending paralysis, I mentioned, ptosis part of that, dilated pupil mydriasis is part of that, that leads to photophobia, diplopia is part of that, decreased coronary reflex is part of that, and even respiratory compromise. So the word botulus is a Latin word, comes from sausage, first described by Juan Erningham as related to the bacteria in 1896. So after 1822 until 96, we discovered bacteria, and then Juan Erningham was able to isolate the bacteria and name the bacteria as Bacterium Bacillus botulinus. And it was from an outbreak of a ham poisoning. And he also did animal experimentation and showed that the poison produced by this bacteria can be inactivated by heat, but not by stomach acid. Botulinum toxin was then discovered to have multiple serotypes 4 years after that. So in 1900, serotypes of A and B were already discovered. In 1946, Ed Shant's laboratory was the first one to purify the toxin into a crystalline form, so pure protein, isolated. In 1954, they were able to show, I don't think it was Ed Shant's lab, but another lab, I think it was McGill lab, that was able to show that this toxin is binding to the neuromuscular junction and is able to block the neuromuscular transmission. So this is the story that started with the clinical use of botulinum trials or botulinum trial. So the Edward Shantz had this toxin available, and Alan Scott was an ophthalmology resident fellow looking for some ways to treat strabismus non-surgically, because at that time the surgical mortality for strabismus surgery was 30%. So he was advised to look into various different toxins by his thesis supervisor, and he was looking around for various one, and somebody directed him to this newly discovered or recently discovered in 50s botulinum toxin, and he was told that Ed Shantz has a lot of supply of it, which he studied for the military use and realized that it cannot be used for military purposes because of the delayed onset, and it's just sitting around with him. So Alan Scott reached out to Ed Shantz and asked for the supply, and he was given this aspirin bottle filled with the toxin to use and for his purposes or experiments. So this is Ed Shantz, who provided most of the toxin that was used all the way up to 1990s, I believe 93 or 96. And Alan Scott was the first ophthalmologist who started experimenting with this use case of botulinum toxin in 1970s. So first animal trial started as far back as 1973, but the first human trial for strabismus was done in 78. And in 1980 was already being used for blepharospasm and hemifacial spasm. 82 was for infantile torticollis and adductor spasticity. And finally, in 1989, FDA approved oculinum for its use for strabismus and blepharospasm facial uses. This is the quick summary of the timeline that we just went through. 1822 was the detailed monograph by Justinus Kerner. 1896, discovery of botulinum, Bacillus botulinum, which is later named as Clostridium botulinum. 1900 serotypes, purification in crystalline form in 46, mechanism of action blocking acetylcholine esterase release in 54, animal trial 73, human trial 78, and 89 got approved for FDA approved oculinum, which was called 97-11 formulation, which was replaced in 1997 later on. And I think until at that time, it was all the toxin being used was from Ed Shant. So Alan Scott was training a lot of people who were coming in on this toxin use case, and he was also handing out all of some of the free toxin that he was given by Ed Shantz. All of this was free. Nothing was charged for any of this. And Alan was just training for free and giving out the toxin for free for other people to go and start doing this practice for strabismus. And then people were trying it for many other things, as we have noticed before. Around the same time, there was another parallel development that was happening in UK in a military science lab. That's where botulinum toxins was studied early on. They also formulated a proper formulation, clinical formulation, is what's called Dysport, based on Porton Products Limited. And in the original military science lab was Porton down. In 1805, the first published use case of this particular type of toxin for strabismus. So a few years later, than the original one in 1991, this type botulinum toxin A was approved in UK for commercial use as Dysport. So 2 years after 89 approval of oculinum. So in some sense, Dysport is before Botox, which was renamed from oculinum later on, I think 97. All right, so this is what the toxin looks like in an unconvoluted form. On the main first screen of this presentation, you saw the 3D or 4D structure of convoluted form of the two toxin, but it's basically two separate toxins. One is called a light chain and one is called a heavy chain. And it's total about 150 kilodalton. 50 kilodalton is the light chain, 100 kilodalton is the heavy chain. They are held together by this weak bonds, which is a disulfide or 2-sulfur molecule bond. And that bond is weakly holding them together, but this bond is necessary for function. So this is what that gets denatured by heat. And that when heat destroys it, then the toxin cannot work anymore, even though the protein is still there. The light chain has a zinc activated active compound that will do the final job, but the heavy chain has these terminals, amino and carbonyl end terminals, which are important for getting the light chain to its final position. So let me show you on a representation on how it looks like. The heavy chain binds to the receptors for acetylcholine presynaptically on acetylcholine nerve terminals, and it gets endocytosed along with that receptor into an endosome or vesicle. This internalization of botulinum toxin, then heavy chain, as released into the endosome, punches a hole or makes a pore through the wall of the endosome and ejects the light chain out into the cytosol. And now light chain can do its job on its own. If that double sulfide bond is broken before this step, then the light chain cannot get into the cytosol. Once the light chain gets into the cytosol, the zinc containing active site on that light chain is able to bind to these docking proteins. The job of the docking protein on the internal side of the nerve terminal is to dock these acetylcholine containing endosomes that are produced by the endoplasmic reticulum, and they are filled with quanta of acetylcholine, all the way up to 10,000 molecules of acetylcholine, and they need to fuse with a membrane to be released when the electrical signal comes to the end of the nerve ending. But that fusion requires first docking of these free-floating endosome to the internal layer, and that docking is done by the docking protein, such as the vesicle-associated monoamine protein, I believe. It's down here. So vesicle-associated membrane protein, and then SNAP25 is synaptosomal-associated protein 25, and then there's also syntaxin, and so on and so forth. And different serotypes, as you can see, cleaves different components of these docking protein. A and E cleaves SNAP25, and B, D, and F. G cleaves VAMP. So we use mostly A, which is SNAP25. There are 4 FDA-approved commercial products of these toxins, and I believe there are, 3 non-FDA approved Asian products. I believe they are from China and South Korea, if I'm not mistaken, but they have not filed for FDA approval, and they do not have an FDA approval and are not available in US or North America, and I'm not sure about their European availability. These 4 products, Botox, which was originally oculinum, Then we have the Xeomin, Dysport. All these three are type A toxins. And then Myoblock is the only type B toxin which is FDA approved. I think all the Chinese and Korean toxins are also type A toxins. FDA required few years ago, I believe 2016 or something like that, that because these are all botulinum toxin A, they should have some prefix to separate them out. And the prefix granted were ANA botulinum toxin A for Botox, INCO botulinum toxin A for Xeomin, ABO botulinum toxin A for Dysport, so that generics can be separated from each other. And then REMA was given to botulinum toxin B. This is what the vials look like. You have the name of the product, their generic name on top of it, and the units in the vial. You have Botox, which has 100 unit and 200 unit vials. You have Xeomin, which has 50 unit and 100 unit vial. You have the Dysport, which has 300 unit and 500 unit vial. And then Myoblock is type B, Rema botulinum toxin B, and that has 2,500 units, 5,000 unit, and 10,000 unit vials. So as you can see clearly already from this description, the toxin units are not interchangeable. So 100 unit of Botox does not mean 100 units of Dysport, because Dysport comes as 500 unit vial or 300 unit vial. So there is no known or easy mathematical formula that can be used to convert the toxins between each other. There are expert opinion, but they also preferably have ranges of conversion, because the unit is defined for each batch of production. So there is no standard unit for all the batches that is the same. Each batch must have their own unit defined, and I will explain that to later on. And the way they are defined, that's why the Botox is coming as a 100 unit vial, and the dose is in multiples of maybe 100, while the Myoblock is coming as 2,500 unit vial or 5,000 unit vial, and the dose may be in multiple of that. So you may be giving 10,000 unit to someone from Myoblock, and you may be giving only 100 unit or 200 unit to someone else with Botox, or so on and so forth. So you should get used to this idea that unit is specific to that particular product. There are alternative products I mentioned. Some of them are probably clinically approved, but there are also non-clinical or lab used or beauty products which are even more dangerous. So you may have something that is available on Alibaba.com, which is a lab-based product that was just being used or being sold as a product to be used for animal research or lab research for particular indications only, and that means that the unit reliability is not low, quality control is not very good, and that unit may not translate as the same as the unit that you're using, and the vial may not have the same number of units. So a vial doesn't mean that it always will have 100 unit. This is a lot of toxin in this vial, so this may easily be 10,000 unit of botulinum toxin A or something like that, and even that doesn't correlate with each other, right? What exactly is a unit is defined by each company on its own methodology. So how is that biological activity or a unit defined? Unit is not a protein weight, so it's not measured in weights like milligram. It's a biological activity, amount of activity. And the way we define this activity is that if you take a mouse, or it's called mouse units, a mouse which is, let me go reverse here. So if you take a 30-gram female Webster mouse and you take 100 of them and you inject 1 unit in each of these mouse, so 100 units, but 1 unit in each of these 30-gram female mouse, then 1 unit will cause paralysis and death of 50 of these mice out of 100. So that is why it's called lethal dose 50 or LD50. So it's a median lethal dose or lethal dose that will be lethal in 50 out of 100 times it's used for a mouse which is a 30-gram female Webster mouse. Now it could be 20-gram female Webster mouse, then you will need a lower dose to get that LD50. It could be a 100-gram female Webster mouse, then you need high dose, right? So weight is important. Female or sex is important because two sexes don't respond to the unit the same way. The Webster or genetics is important. Not all mouse species will respond the same way. Now we don't measure the units anymore this way. This is how they were originally defined. We later on started using the diaphragmatic assays, where we were using a diaphragm of the mouse multiple times to try to measure each batch by batch mouse units LD50. And then I think later on now we just do some form of an adsorption assays. I'm not exactly sure how we do it now, but I've been told that it's not based on the mouse diaphragm anymore. Let's look at some differences between the four products that I mentioned, which are FDA approved. I'm not sure that you have them in Pakistan, but many people do bring the toxins with them too. And there is a fifth FDA approved toxin that is not part of this presentation that got approved recently, maybe a year and a half ago, which is called deoxybotulinum toxin A. And that is a modified form of incobotulinum toxin A, or the pure toxin A, with an adjunct protein added to it. And I'll be happy to talk more about it if you guys have questions in the workshop. So Botulinum toxin A is purified by acid precipitation. So once you grow the culture of bacteria, you let them produce their toxins, proteins. Now the broth is full of all these toxins, and you need to get the toxin out without getting the bugs or bacteria. You may or may not kill them. And you start purifying by using an acid precipitation, precipitating the toxin out by joining it with an acid. You then do a sterile lyophilized toxin purification into that vial, and you end up with a crystalline complex that contains toxins with complexing proteins. Complexing proteins are normal proteins that are normally present around the toxin protein that I described, the 150 kilodalton, inside bacteria. When the bacteria produce the toxin, it doesn't just produce toxin, it produces some additional complexing proteins with it. So in botulinum toxin, what we are left with are the two 300 kilodalton accessory proteins that are dimerized, and they are associated with the 150 kilodalton toxin that is wrapped by them, and you get a total size of a 900 kilodalton. So much larger protein than the pure toxin itself. In nature, these accessory protein have a function in terms of protecting the toxin and also helping with penetration of the toxin into the tissue. Some of them will agglutinate the protein, heme protein or blood, and they're called heme agglutinating, and others will not agglutinate the heme protein, and they will call heme non-agglutinating, and there are many of them that I even don't know the details about. You get a single use glass vial, which is either 100 unit or 200 unit, and it's about, in 100 unit glass vial, they do have about 0.5 milligram of human albumin and 0.5 milligram of sodium chloride as a stabilizer, and it's vacuum and a dried powder, and there is no preservative inside. And unopened vials must be refrigerated 2 to 8 centigrade for it to last the shelf life. If you do not preserve it that way, then it will not last the shelf life that I will show later on. Incobotulinum toxin contains only toxin. It has no accessory protein with it, so it has been completely purified, and it is now 150 kilodalton. It is also white to off-white powder, and it comes as a 50 to 100 unit vials, which contains 1 milligram human albumin and 4.7 milligram of sucrose. This unopened vial can be left on room temperature as long as the temperature is around 20 to 25 centigrade. It can also be refrigerated in 2 to 8 centigrade or even in a freezer, and then it will last even longer. So shelf life on room temperature, especially, but room temperature does not go above 25 centigrade. If it's a really hot room, it's a direct sun exposure, that might still damage. Remember, heat will damage the disulfide bonds. Dysport is purified by series precipitation, dialysis, chromatography steps, and it is containing hemagglutinated protein and non-agglutinating protein, 300 kilodalton L complex and 600 kilodalton M complex. So it is a much bigger protein with the toxin. It comes as a single use 3 ml glass vial of 300 units, and then also 3 ml glass vial of 500 units, and contains lyophilized toxin and 125 milligram of human albumin, much larger albumin, and 2.4 milligram of lactose rather than sucrose. And unopened vials can be stored at 2 to 8 centigrade of refrigerated. So only Xeomin out of the type A can be stored on a normal room temperature. The myoblock, the type B purified toxin, is produced by fermentation of the bacterium, and type B purified through series precipitation and chromatography. And toxin has non-covalent associated with hemagglutinating, non-agglutinating proteins of a total 1,250 kilodalton. So really large protein with it. When you extract it, it still remains liquid. You do not precipitate it into crystal. So that liquid, because it is coming from fermentation of bacterium, is actually acidic. So you get a colorless to light yellow, sterile injectable solution, but has a pH of 5.6. So this pH will sting. Even when you put we don't use dilution for it because it comes pre-diluted. It's a single vial glass. It has only 0.5 milligram human albumin, sodium succinate, which gives it some of that acidity, and 0.1 mole of sodium chloride. and it does remain refrigerated. You do not freeze it because it's a liquid. You can damage it. You do not shake it, and it can be diluted with normal saline, but most will inject it as it is, and that gives a little sting to the injections. I don't think that I've seen anyone use it in Pakistan or heard about it. So usually it's type A toxin that is being used in Pakistan. So this is a summary of this comparison and the vials. There is some differences in how they are prepared and how they're used, because mostly it's the Botox which is used in Pakistan because it's the only Pakistan FDA or DRAP approved in Pakistan. I will focus on that towards the end of this talk. Shelf life for storage for a Botox vial is 36 months unopened, 24 hours after opening the vial if you refrigerate it, and 4 hours if you open the vial on room temperature. So you use it on 4 hours if it's on room temperature, and if you are going to refrigerate it, you can use it up to 24 hours, and only unopened vial in refrigerated 2 to 8 centigrade you can last for 36 months. Storages are similar for other drugs, but I'm so focusing on Botox now. There are specific FDA approved indications, although there are many unapproved indications that we use it for all the time. I have not updated this list. This is from 2016. I've not gone back to update the list because we don't follow the list, but gives you an idea that these are the kind of conditions that have been looked at. It has been FDA approved for urinary incontinence by detrusor overactivity. You can do bladder injection, headache, migraine, chronic migraine, upper limb spasticity, cervical dystonia, severe axillary hyperhidrosis or excessive sweating, blepharospasm, and strabismus. But as I mentioned, there are many unapproved indications that we use it all the time that we can talk about in the workshop. Xeomin has much limited approvals, only for cervical dystonia and blepharospasm. Dysport only for cervical dystonia, upper limb and lower limb spasticity, including pediatric approval. And then MyoBlock is only approved for cervical dystonia by FDA. All of the toxin carries a black box warning. Black box is a mechanism used by FDA. They put a black colored box on the label, meaning that the insert in the drug vial, and that insert has this black box showing that there is something seriously significant abnormality that can happen with this drug that the patient should know, the doctor should know, doctor should tell the patient about it. And it's saying that there is a possibility of distant spread meaning that you gave the injection only on the face or on the neck, but it went to the whole body, arms and legs, and including diaphragm. And this distant spread can lead to symptoms of botulism that I mentioned earlier in the study, earlier in this presentation, that will include swallowing difficulty and breathing difficulty, and it can be life-threatening. Risk is probably greater in children treated for spasticity with high doses, but that has not been proven beyond doubt, and it has also been reported in adults, even at lower doses. I believe that the lowest dose this has been reported is with 200 units. So less than 200 unit has not been reported, but above 200 has been reported. I do think that the severity of the symptoms are dose dependent. So a 200 or 300 generalized botulism may give only mild swallowing problem, maybe no breathing difficulty, while 800, 900 will become significantly abnormal. All right, this curve is the response curve. This basically shows you what happens when you give the injections to the patient. When you give the injection on day 0, it kicks in about 5 to 7 days. But there is a large variation around this, depending on whether it was a first injection. A first-time injection may take all the way to 2 weeks to kick in, or sometime it doesn't kick in if you did not give enough of a dose, or it may kick in a little sooner if you give a lot of dose. So this somehow is dose dependent, this onset. So it's a threshold of a response where the patient will start feeling the response, and that threshold may reach sooner if you give a higher dose. On a repeat injection, especially once you've figured out the stable dose, it usually kicks in 3 to 5 days, often closer to 3 days, depending again on your dose. After it kicks in, it continues to give better improvement. In most patients, the peak is reached on average around 4 weeks. But again, this can be a variation. It could be 2 to 6 weeks, depending on first dose versus repeat doses and amount of dose given. And then it gradually wears off, and you start having recurrence of symptoms noted by the patient anywhere from 2 to 4 weeks before the next injection, which is at 3 months. So 2 months 2.5 months after the injection, you start some wearing off, and then around 3 months, we think patient has significant wearing off, and we repeat the injections again. Now, again, this is very much dependent on the number of injections. Is it the first session or is it a fifth session? It also depends on the total dose being given. It also depends whether there's side effects or not from the dose or not. Many things will adjust this curve. However, in general, this is kind of the landmark you can follow, that a week to kick in, a month to peak, 2 months to start wearing off, and 3 months to repeat the injections again. And we can talk in workshop on this kind of a curve and how to change the response curve, or what changes this response curve. If you give too much, you have too much of a response and you get into side effects, and you go above the good response. If you don't give enough, you stay below the threshold of benefit or barely touch it, and you will get no response whatsoever. So you need to give enough that you get good response without overshooting too much. All right, let's get back to Raza and see some of the other concept. I think I've clarified some of the previous concept. You don't want to use the drug which is 2-day old, especially if it was not for sure refrigerated to 2 to 8 centigrade. And you also don't expect benefit to kick in for a week, and patient will not have an immediate benefit at that time. And if they don't get a response, it may be that there was not enough drug given. So the next time you will increase the dose. All right, so Raza is excited about getting injections. He drives a truck for a living, and this disease has almost destroyed his livelihood. You bring in the vial to give him an injection and decide to give 20 units on each eye divided over 4 sites. Divided over 4 sites meaning that 5 times 4, or 20 units on each side. The vial seems half full, and your resident draws out 1 ml from the vial and hands it over to you. Okay, here's an ml, 1 ml of injection. Go ahead and give 20 units on that, each eye, or 5 times 4. And you ask him, how many units do you have in this syringe? So you're asking the residents, you gave me 1 syringe. Okay, here's give you 20 units. Well, how many units are in the syringe? Are they 50 units? Are they 100 units? Are they 20 units? How much is in a syringe, right? So the question is that how many ml would you inject Raza? And how many units will you give him? And where would you give these sites? So that brings me to this question of dilution. So the reconstitution or dilution procedure, I want to go through that a little bit. This is the standard recommendation. I do not follow them. So I use only 1 ml in 100 unit every single time. And that's where I get 10 units per 0.1 ml or 100 units per 1 ml syringe. So if my student was coming to me and already the bottle has only half left, then I have no idea what the dilution is, right? That the bottle must be prepared in front of me. So what do you need to prepare the toxin, or what supplies do you need when you do? All right, here are the typical supplies we use in a Botox clinic for both dilution and injection. On the top left, you'll see the Botox box with the Botox vial inside. Then you see the 2 1cc syringes. It has normal saline already poured in. You see these big, large needles. They are specifically used for reconstitution, not for injection. They are thick bore, typically 20 gauge or even 18 gauge, and they are 2 inches long. You need them for preparation, as I would show you later on, as you do not want to invert the vial. So you need at least 1.5 or ideally 2-inch long needles to be able to do it effectively. Then you have the 2 EMG guided hollow needles. So these are EMG needles, but they have hollow core. So you can actually hook up with a 1cc syringe and inject through them while you're doing EMG. You have the 0.9% sodium chloride. You want preservative free. Preservative will damage or destroy the botulinum toxin. You have the reconstitution needle here, and then you also have the 2 small face injection needles. These are 1/2 inch and they're 31 gauge, very, very tiny and narrow. 30 gauge will be okay, but 27 gauge will be less than ideal, and you definitely want something very tiny so you can do subcutaneous injection for the facial injections. And then you have the 2 1cc syringes. I use the slip lock for lure lock injections. For my syringes, there is also a turn lock or rotating lock that is available, which makes it so that the needle don't slip off that easily, but then it makes harder to switch between the syringes if you are doing multiple syringes with the same needle on a same patient. So you draw the normal saline 1 ml. You go a little more above 1 ml because you will get some air in it no matter what you do, a few bubbles. And when you inject this into the glass vial, some of it will get stuck to the glass as a thin film of water on the glass, so you will lose some. If you put 1 ml in perfectly or precisely, you will get only 0.9 ml back at best. maybe 0.85 or zero point 0.8. So we usually use 1.1 or 1.2 ml. It does not have grading for 1.1, 1.2. So you just draw as much as you can all the way above 1 ml until the stopper stops or plunger stops. And if you pull any more, it will just come out. So you go all the way you can, and you want to try to minimize the amount of air coming in by inverting the normal saline fluid that way. And it is showing you how far we have gone. So this is 1 ml, and then we are almost 1.2 ml above how much we have gone. And then you poke that needle, the reconstituted needle, into the top of the Botox vial while the vial is straighter, not inverted. And then you let the vacuum suck the normal fluid out of the needle or syringe into the bottle on its own for two reasons. One, you want to see that there is vacuum seal in this vial, and this vial has not been punctured before and vacuum has been lost. You do not want to use a vial if there is no vacuum. The other reason is that you want the fluid to drip in slowly into the vial. Anytime you push the fluid fast into the vial, it will cause agitation, it will cause frothing or bubbling. Froths or bubble will trap the toxin because toxin is a protein and would not come out or be drawn by your needle anymore. And you will lose that amount of toxin. It may be a small amount, maybe 5 unit, 10 unit, but you can lose some toxin by frothing inside the vial. So you want to let it drip slowly, gradually on its own without pushing or squirting the normal saline into the Botox vial. And then you break the vacuum. You take the syringe off and let the needle sit in the vial, and you can hear an air sucking in. Now, one thing I do is that I pull the needle back a little bit so it's not touching the wall. But here, what my nurse has done is to tilt the vial so that the fluid is down here in the bottom and the needle is outside of the fluid, because that quick sucking of air breaking the vacuum can also cause bubbling or frothing of the fluid. And then you want to make sure that it mixes well. You want to do two things when you mix. Number one, you do not want to invert the vial. And number two, you don't want to shake it. You want to just gently roll it. And when you roll the vial, you make the fluid kind of swirl around at the base. That's where all the toxin is in a Botox vial. In a Xeomin vial, the toxin is all along, can be all along the wall because it's just a powder. But here is a ring deposit on the bottom of the vial. So in Botox, you just swirl it gently. You do not invert it because the cap inside have projection and has groove around it, and it can trap more fluid. You can lose another 0.2 ml there or more. So you don't want to invert it, and you just want to gently swirl it. All the toxin is down at the bottom of the vial for Botox. And then you put your syringe back on to that needle that you left in the bottle. You find this space gap between the two sticker or the one sticker that is rolling around the vial. You turn the cut end of the needle towards you, facing you, and you tilt the bottle so that this becomes the lowest part of the bottle. So all the fluid kind of comes and drops down over to that end. And then you start withdrawing the fluid. And that way, because the center is raised, if you are drawing from the center, then there may be fluid left at the corner that you did not pick up. And if you get air pulled in, then that can cause frothing. So you want this point where you're drawing as to be the lowest point in the bottle by being tilted. Right now, this is not the ideal way. So she's just showing it after she has drawn all of the fluid, and you can see nothing is left once all the fluid has been drawn back in the syringe. And then you take the syringe back out, and this needle stays in the bottle to avoid any injuries from the sharps, and you can throw it away. There is a lot number on the box and the bottle, so make sure you do write down the lot number in case you need a recall from any damage to the vial. So that was reconstitution. I'm going to quickly touch on the final topic briefly, but I'm happy, which is immune resistance. So let me review immune resistance a little bit, but I will be happy to discuss more about it during our workshop. So immune resistance is where there was a benefit in the past, and now the patient developed an immune attack or against that protein, which is a foreign protein, which is coming from a bacteria. It's a toxin, and that is now making that ineffective, and the benefits are gone. So previous benefit, which is gradually lost at least after 2 injections. And on follow-up, there is lack of muscle atrophy, meaning that the drug is just not working, and there is no denervation on EMG and no side effects. So that's a true or pure immune resistance or complete immune resistance. You don't see all the time a full immune resistance, meaning that there may be a partial immune resistance where the drug still works, but just does not work as good or only work 30% or 40%. So there may be still some denervation on EMG. but there should be no side effects and there should be no atrophy of the muscle. And it should be after successful benefits first. Otherwise, it would be called a primary failure, and that could be because you didn't use the drug right or you didn't plan the injections right, and so on and so forth. So, what makes someone develop an immune resistance? We think that it happens more often when we give injections more frequent than every 3 months. We give them every 6 weeks, every 4 weeks, or something like that. If we give in between booster injection, you give a full injection and then there was 60% benefit, 70% benefit, and you want to make it better. So a week or two later, when the drug kicks in, or a month later, you give a little bit more to get some more benefit out of it. Or if there is increased protein content of the toxin, maybe a reason for developing immune resistance. So those preparations that have a lot more protein, such as the Dysport and Botox, may have a higher risk than something like Xeomin, which has lower protein content. And then the larger doses of botulinum toxin is also considered a factor. So more than 300 units of botulinum toxin dose at a given injection session, or over time as their larger cumulative dose, someone who's getting it for 5 years or 6 years, regularly every 3 months, has now gotten thousands of toxin units over time, may be a risk factors for developing immune resistance. So it's not very common. I would say it's less than 1%, so less than 1 in 100 patients. So antibodies, they form against toxin polypeptide or against the accompanying protein complex. And it is likely that only some of these antibodies are neutralizing and contribute to the reduced efficacy, which means that many patients do develop antibodies that you can actually measure them in their blood, but they don't have immune resistance. They're still responding completely fine, and that incidence may be 20 to 30%. So 2 to 3 out of 10 patients with Botox regular injections, botulinum toxin regular injections, may develop antibodies that you can measure in their blood by various tests, but they do not have immune resistance. So very few have the neutralizing antibodies. Non-neutralizing antibodies can be present and do not reduce effectiveness. Initial reports of antigenicity were based on observation from the early preparation from 1979, called 1979-11. That was from Ed Shant's lab, and that have rate of antibodies of 4 to 10% in patients treated with cervical dystonia. The higher protein load of that preparation compared to currently available 1997 Botox preparation, and there may have been another revision that may have made it more antigenic for the older one and less antigenic for the newer ones. And newer manufacturing techniques seems to have reduced the risk to 0.5%. So really, really low if you know what you're doing. How do you measure or figure out the immune resistance? You can do the antibody testing, but as I mentioned, majority of patients have antibodies but do not have immune resistance. So you can do antibody testing by ELISA or immunoprecipitation. You can do a biological function testing, which will tell you if there is resistance or not, through mouse neutralization assay or mouse semi-diaphragm assay. Again, those are not easily available tests. So what we usually do is a clinical testing, that we take a target, which is an easy target, and give it a very big blasting dose, and to see if there is a clear paralysis of that muscle or not. So the easiest one to do is the eyebrow or frontalis test. So you can see me raising my eyebrows in the camera, and if I give 50 units or so of toxin on one side of my forehead, and then I raise and my one side of my forehead does not raise, then that will tell you that the drug worked. And so you give the injection, which is high dose, usually 30 to 50 units, and then you give it on one side. You take pictures of before of both foreheads, and then you ask the patient to either come back in a month where the peak benefit is, or you ask them to take pictures at a month and bring it back 3 months later and to show you if there was a response to the toxin or not. And that way you can decide if the drug is still working or not. You can do the same thing for sternocleidomastoid. I don't see many people use it anymore. Some patients still use extensor digitorum brevis or EDB testing. I have not used it. I've always used UBI, but that has been only like 3 times at most in the last 15 years. All right, that's all I had. I want to thank you, my team in Nebraska who prepared me, especially my mentor, Dr. Torres Risotto, who trained me everything about Botox, and my mentor, Professor John Bertoni, Professor Daniel Merman, and the wonderful team in Nebraska who helped me know all that I know now. Thank you so much.